Good evening, everybody, and welcome to this evening's webinar. My name is Dr. Nate Lighthizer, and it's my pleasure to be here and to talk to you tonight about how to utilize OCT angiography to detect and manage diabetic retinopathy. I am a professor, actually an associate professor at the Oklahoma College of Optometry, where I serve in various roles, one of them being the head of our specialty care clinic, where we're very fortunate to have OCT technology, and for the past almost 3 years, OCT angiography technology as well. So at our practice, we get to manage a lot of pathology, including diabetes, diabetic retinopathy, macular degeneration, glaucoma, among many other conditions. So we're going to focus tonight, again, on how to utilize the OCT angiography, or OCTA as we'll call it, to detect and manage diabetic retinopathy. So again, as we get kicked off here in our going forward, when you think about OCT angiography, it is really the next chapter in posterior segment imaging. And I'm actually going to go back for just a second. If you guys have any questions throughout the webinar, please feel free to type them in the question and answer session down there. We're going to have about 40 to 45 minutes of lecture as we go forward. And at the end, we'll have plenty of time. We'll finish this hour over the course of the last 10, 15 minutes or so on a Q&A. So if you have any questions throughout, please feel free to type them in on the Q&A section and going forward at any time throughout this webinar or presentation. So when you look at OCT angiography, it really is the next chapter in posterior segment imaging. I started my OCT education and training with the time domain OCT, as you can see on the bottom left, and then we moved to spectral domain OCT, more high definition, more axial scans per second, better resolution to be able to image those 9 or 10 different retinal layers. And now, again, the next evolution is into OCT angiography, as that's been around for a number of years now. It's been FDA approved for 2 or 3 years at this point, and it just allows you to image the retinal vasculature in a way that we couldn't do before without an injection. We all know fluorescein angiography has been able to allow us to evaluate the vasculature, leakage, pooling, etc., capillary dropout, and now we can do that with OCT angiography. Not all of those things, but many of them, especially the capillary structure, the retinal structure in terms of vasculature. So it displays structure and vascular integrity, vascular function from a single system, and I think that really is a game changer to have structure and vasculature integrity or vascular function all in one. And we're going to go through a lot in the next 45 minutes on interpretation. How do you look at these scans? What is normal and what is abnormal? And this is a scan, again, we're looking at the foveolae vascular zone, and we'll go through the 2 or 3 different metrics that I like to look at when we're evaluating these patients, whether they have diabetic retinopathy or whether they're a normal or whether they have retinal vascular disease. So again, to have that B-scan structure, that image on the right, and then to have the function or the integrity of the vessels on the left certainly has been a wonderful addition to our clinic. Patient benefits, certainly you can more frequent imaging, you get more information, and it's much faster than a dye-based procedure. I practice in Oklahoma, where we are allowed to do, it's within our scope of practice to do injections. I've done many a fluorescein angiogram from when I trained in my residency in 2009 through today. They are decreasing in number because of OCT angiography, because it's just a faster than that fluorescein angiography dye-based procedure, and it gives you a nice visualization with these en-face images. If you're not familiar with en-face images, take a look at those 4 images on the bottom, and those are really 4 different slabs through the retina, going deeper, deeper, deeper with each individual slab. On the left side, starting with the superficial capillaries, on the right side, going down into the choriocapillaris. And again, we'll go through this in a little bit, but familiarize yourself with en-face technology, en-face imaging, those different segmentation slabs that you'd like to call them, going through that different interpretation with OCT angiography. So how does the technology work? Well, it works via motion contrast. It takes sequential different B scans over the course of a few seconds, and the only thing that should move from an OCT image right now to an OCT image 1 second later is what? And the answer is red blood cells or blood in vessels. So those red blood cells are able to be imaged, and that motion contrast, the system is able to detect that, analyze that. The software obviously does a great job and can tell you what is moving, what is flowing versus not. So it's motion contrast over multiple different scans taking in the exact same spot on the retina, and nothing should move, except blood or red blood cells. And flow, again, is the difference. This video is not going to play tonight, but you can see this picture of a faucet. And if we could play this video, the only thing that's moving on this motion video here is going to be the water, because you can image that from frame to frame to frame. Flow is the difference between those two frames because it's the only thing that's moving. So it's motion contrast is the answer to that question. So here's back to our en face OCTA. And this is going back to the retinal anatomy. If you look at that central or center different OCT B scan, and you can see a nice normal anatomy of the central part of the macula, the fovea. And each of these different slabs is coming from a different area in a cross-sectional analysis of that retinal OCT. And you can see we've got the superficial capillary plexus, and then a little bit deeper, we've got the deep capillary plexus. And then you go over to the right side, and we've got the outer retinal zone, which is really the RPE. And then a little bit deeper, you've got down into the choroid. So slice by slice by slice. And I like this because it gives you the ability to look at different layers within the retina from directly straight on. We all are familiar with fundus photos, where you can take a look and you can see the anatomy. Well, now you can go layer by layer by layer in en face imaging. This is useful in more than just diabetes and diabetic vascular disease. During my talks, I always introduce en face imaging with this case, and that has nothing to do with OCT angiography, but it introduces the technology in terms of those en face images. This is a 60-year-old female that was sent in by a retina specialist for some electrophysiology testing, and the patient had decreased vision in the right eye more than the left eye. And the retina specialist looked at the scans and said, I can't figure out why this patient has decreased vision. Obviously, the retina specialist knows what he or she is doing with the retina, has taken a look at the back, dilated fundus exam, done an OCT. And you take a look at the OCT, and this patient has an epiretinal membrane. But I bet we all agree that this epiretinal membrane is not a 20/60 epiretinal membrane, especially in that right eye. I would expect that vision to be 20/30, if not better, in the right eye. But yet it was down, so that's why some further testing was wanted by the retina specialist. Well, when you take a look, again, there's another view of that OCT, of the epiretinal membrane, and you can see it's a mild ERM, slight loss of the foveal depression, especially in the right eye, but also in the left eye as well. Vision's down a little bit in the right eye. When you take a look at the en face imaging, look at those four images across the top, and you've got the internal limiting membrane, and then you've got the IPL, and then you've got the RPE, and obviously the image on the right is the choriocapillaris, layer by layer by layer, and they're all going to highlight different things a little bit differently. But the one on the left is going to highlight the diffuse nature of this epiretinal membrane, and whereas the membrane appeared fairly mild here, it was a fairly significant epiretinal membrane in terms of the area and the diffuseness of that. And again, it's just really shown well on the en face imaging, or the en face slabs, as you can see there. OCT angiography works very, very similar, pretty much identical, as we'll look at that in just a little bit. So remember the en face slabs. And there's your anatomy. And remember your anatomy of the retina when you go through this, that the retinal blood vessels are located on the inner retina. The inner half of the retina is where the retinal blood vessels are located, and therefore that's your superficial capillary plexus and your deep capillary plexus. And when you look at that, we're going to go through normal in just a little bit, that you're going to see a nice, what I call a plushness or a lushness, whatever you want to call that, just a nice capillary network, a tremendous amount of vessel density in those two scans on the left, the superficial plexus and the deep plexus. You go a little bit deeper into the outer retinal zone, there's the RPE, and then the choriocapillaris as well. So again, just kind of highlighting the en face visualization based on the retinal anatomy, as you can see right there. So what is normal? You can't understand what abnormal is until you know what normal is, until you go through these scans. So I want to spend a few minutes looking at a normal scan. This is a healthy 25-year-old optometry student from our College of Optometry here at NSU in Tahlequah. And you'll take a look, and this is as normal as it gets. And you take a look, and this is the overview slide. And you can see we've got a nice overview slide of our four en face images at the top, the superficial capillary plexus on the left, and then the deep capillary plexus, and then the RPE or outer retinal zone, followed by the choriocapillaris. You can see the nice retinal vasculature on the two en face images on the left. Notice they have a nice capillary network. You can see the large retinal vessels, but you can also see the dense capillary network. The only area where we're not seeing that is obviously in the center, which is the foveal avascular zone, or the F.A.Z. Stay tuned, for the rest of this presentation. We're going to talk a lot about that foveal avascular zone. It should be of a certain size, a certain area. It should have a certain perimeter and a certain capillary density, and we can now measure that with OCT angiography versus you couldn't see that with a fundus photo. We couldn't image that with regular OCT, and now you can with OCT angiography. So this is a very, very normal, what you expect the two on the left to look like. You can see a nice capillary network. The vessel density is very, very normal. You move to the third from the left, or second from the right. This is the outer retinal zone, or the RPE. Notice it's pretty much black, because should there be any vessels in the outer retina? The answer is no. There should not be any vessels in the outer retina, so for the most part, this should be pretty much black because it's not imaging any blood flow. There's nothing moving in this layer of the retina. You move over to the one on the far right, and now we've got the choriocapillaris, which is obviously, as we all know, densely vascular, and it's basically like a sponge of all of this vasculature, and you're going to see not the capillary network, but kind of that white vascular sponge, as you can see in the choriocapillaris there. What you want to remember, when you're looking at this, again, this is a very normal 4 segmentation slices or en-face slices as you're going through this. The two on the left are what I evaluate clinically in patients with diabetes, diabetic retinopathy, vein occlusions, artery, retinal vascular disease. You want to pay more attention to the two on the left. The two on the right are more for your outer retinal pathology, things like macular degeneration, maybe histoplasmosis if you suspected a CNVM, pathological myopia, central serous, chorioretinopathy, again, if you suspect a CNVM, those types of conditions that cause outer retinal pathology, you're looking for the two on the right, the development of an abnormal vessel that shouldn't be there. So those are your 4 slices. You can see your 2 B scans on the bottom right, as we're all familiar with those OCT B scans, and the image on the bottom left is the OCT angiography overlaid on a fundus photo, as you can see there. Of note, this is a 3 millimeter by 3 millimeter scan. I typically clinically now do a 6 millimeter by 6 millimeter scan. It takes a little bit longer, but really not so much. I mean, the technology now has evolved to have scan acquisition be much, much quicker. So my protocol is a 6 millimeter by 6 millimeter scan for most retinal pathology, particularly in diabetes and diabetic retinopathy. You can go beyond that. You can go to an 8 by 8 millimeter as well. But again, our current protocol is a 6 by 6 one we're looking at. So this is normal. You can then hit the exit button in the top right. You hit that exit button and it will break it down into the individual images. And you can take a look. We've got OCT angiogram on the left with the B scan below. And we've got the structural en-face on the right with the B scan below. Now, I'll call your attention just to the right of this, OCT image, and you'll see a superficial, deep, outer retina, and choriocapillaris. That's how I click through to get to these individual images. Right now, we're on the superficial capillary plexus, as you can see on the left, that nice, dense capillary network, foveal avascular zone in the middle. If I wanted to go one layer deeper to the deep capillary plexus, I would hit that deep button on the right, and it's going to take me to this. And you can see now the deep is highlighted. And if I wanted to go a little further to the outer retina, there's the outer retina. And you can see, again, this is now individual layer by individual layer instead of the overall summary slide, as we saw a couple of slides ago. Nothing really to note here. There's no vessels in the RPE. We're not showing any vessels whatsoever. One layer deeper down to the choriocapillaris, that vascular, sponge or that dense vascular tissue down there. So that's how you go layer by layer by layer if you want to image that a little bit more. The last thing I'll call your attention to is if you look at the top of this, you got signal strength index, but just below that, there's like 5 or 6 different tabs there. Make sure you're on the en-face tab when you're looking at this. Now, it should default to that, but make sure you're on the en-face tab, and that's especially important when we get to analytics in just a little bit, so we can then select F.A.Z, or we can select vessel density, or flow or non-flow, you want to make sure you're on the right tab. So again, the on-FOS tab, and we'll go into this in more detail in just a little bit. So that is an interpretation going through your slabs. Once again, here's the overview slide of what is a very, very normal in a healthy 25, 26-year-old optometry student. No pathology here. This looks great. The two scans on the left, the F.A.A.O is of appropriate size. We have no capillary remodeling, no capillary dropout, no areas of non-perfusion. This vessel density looks very, very good in this scan right here. So when do we utilize this? OCTA in our clinic. Certainly there's a number of reasons. Macular degeneration, it's been huge. Diabetics, it's been huge. Retinal vascular disease, it's been huge. And in glaucoma, it's emerging more and more every single week that we use this. And we've been using it for quite some time, but glaucoma as well. Tonight the talk is on diabetes. You know, other experts are going to talk about AMD and glaucoma as well. So we're going to talk about diabetes tonight. Why is this important? What's happening to diabetes and the rates of diabetes? We all know that it's increasing. You know, there is 25 to 30 million, and I just read a study that said even beyond 30 million Americans now have diabetes. And it's the leading cause of visual impairment in working age adults. Unlike people that get macular degeneration that tend to, if they have vision loss, it's in their 60s or 70s or 80s or maybe even beyond. Diabetes, if they have vision loss, it may be in their 50s or 40s or maybe even 30s depending on the case. So certainly it's something that we need to pay attention to, and we may be managing this for the long haul because your patient may be in their 40s or 50s and you've got that patient for the next 30, 40 years, hopefully. Again, it's increasing. 25 million Americans based on this statistic. I just read one over 30 million. And this number is expected to go over, I just read it, 50 million people by 2030. In the next 11 years, that number is supposed to almost double to over 50 million. So we are going to have to manage this more and more in terms of diabetic retinopathy and managing these cases. Even more scary than that is over 80 million. I know it says 79 million there, but over 80 million have prediabetes, have impaired glucose levels, and that number is expected to go over 100 million in the next 10 years. More and more are developing diabetes and more are developing prediabetes, and we need to just be aware of that, and we're going to be managing that. Retinopathy rate is about 30 to 35%, depending on the literature that you read, and certainly that's important, and there's multiple risk factors for the development. We all know that the longer a patient has diabetes, the more likely they're going to develop diabetic retinopathy. The type of diabetes they have. Type 2 is more likely to develop diabetic retinopathy as they get into year 10, 15, 20, than type 1. Excuse me, type 1 is more than type 2 on that, excuse me. So what are the rates of type 2 diabetes? Type 2 diabetic retinopathy. At 5 years, you're type 2 diabetic, that's the rate. If they're on insulin, it's a little bit higher than if they're not on insulin, but 1 out of 4 or 4 out of 10 are going to have diabetic retinopathy. At 19 years, that's going to increase. The point is, we know that diabetic retinopathy is going to become more prevalent and the incidence increases the longer your patient has diabetes and therefore diabetic retinopathy. Scary numbers here when you take a look at this for me. Of your patients that have no retinopathy, 1 out of 10 to 1 out of 20 will have retinopathy next year. So if we looked more closely with an OCT angiogram, when I'm saying they don't have retinopathy this year, maybe now that we have an additional tool, maybe they did have some subclinical retinopathy, enlargement of the foveal avascular zone, capillary dropout, now that we can image that. Mild NPDR, 16% will have proliferative in 4 years. And we know there's stages in between. They had to go from mild to moderate to severe to proliferative. And if there's ways that we can track them better, I think it's imperative that we do that. If they've got severe NPDR, within 1 year, 50% will have PDR. So I think that's critical that we monitor that going forward. The macula can go both ways. I'm certainly guilty of this. When I have managed this in the past, is we're all so familiar with the macula in diabetes doing this, correct? Diabetic macular edema. And we've done the OCT that shows it so well, that diabetic macular edema or CSME, but don't forget that the macula can go the other way as well. Have you ever had a long-standing diabetic that has had cataract surgery and was 20/25 or 20/30, and you looked at the back of the eye and said, there's no exudates in the fovea or the macula. There's no bleeding in the macula. Why is their vision only 20/25 minus or 20/30? And then maybe you did an OCT scan and it was a little bit thin. Well, I'd challenge you to think about, do they have diabetic macular ischemia? We know the macula can go both ways, DME or DMI, and the traditional standard for imaging diabetic macular ischemia was a fluorescein. Well, and we know it predicts diabetic retinopathy progression, and 41% of patients with diabetic retinopathy had some degree of macular ischemia. And the more ischemia they have, the quicker they're likely going to progress through the stages of diabetic retinopathy. And we likely should follow that patient more closely, more exams, more testing. Maybe we now consider a diabetic supplement now that more and more people are considering and seeing the need for those. We may need to do more testing and more treatment on these patients. So detecting that diabetic macular ischemia may be critical. And here's why, because it can be tied to vision loss. Most of the patients that lose vision from diabetic macular ischemia have moderate to severe ischemia. Well, maybe now we can detect it at the mild stage when they haven't had vision loss. They've got the early signs of thinning, or maybe they don't even have macular thinning yet on the OCT, and you start to detect that F.A.A.O enlargement, capillary dropout, the vessel density is decreasing, all early signs of macular ischemia, and we educate more, and maybe we can intervene, and it's ultimately up to the patient to some point. But now that we can educate and detect this earlier, I think we have better long-term outcomes for the patient as well. Instead of them getting to that moderate to severe ischemia and potentially losing vision, now we detect it at the mild stage and intervene sooner. So remember, the macula can go both ways, both edematous as well as thinning from that diabetic macular ischemia. What are the advantages of OCT and F.A.A.O? Certainly OCT does a fabulous job with structure, retinal layers, retinal thickening or thinning, and the fluorescein does a fabulous job of that retinal and vasculature. Capillary dropout, capillary ischemia, retinal ischemia, non-perfusion, and identifying leakage, things like that, pooling, etc. But that's also one of the downsides of the fluorescein angiogram is that leakage, that pooling, that staining may obscure underlying details. So there certainly is a place for a fluorescein, and it can image much more peripherally, which is nice. It requires less fixation, which we'll talk about in just a second. It has a very nice use, but OCTA provides some nice benefits of a much quicker test, much quicker acquisition in terms of 8, 10, 12 minutes for the fluorescein angiogram. It's a matter of seconds for the OCT angiogram, as you can see there. So what are the advantages? First thing I'll identify is the early stages. That's going to be my take-home point, again, over the course of the next 20 to 25 minutes, is earlier stages of diabetic retinopathy. We wait until the MA appears, the microaneurysm, the hemorrhage, the exudate, whatever, the venous beating, the ERM, which are moderate stages. But instead of waiting for that MA to appear or that hemorrhage to appear, can we detect it sooner with maybe some capillary dropout, foveal vascular zone enlargement? And I'm going to go ahead here just a couple, and I'm going to come back to this. This is what you want to remember, the take-home message of the things that you can see before they bleed, before they have hemorrhages, is maybe macular ischemia, enlargement of the foveal vascular zone. I was doing a quick search last week for different studies, and I came across a study that was released last week, released early March of 2019, and it was titled Enlargement of the Foveal Vascular Zone Detected by OCTA in Diabetic Children Without Diabetic Retinopathy. These children have diabetes. They don't have diabetic retinopathy. They imaged this with OCTA, and they clearly showed that the F.A.A.O gets bigger even when they don't have diabetic retinopathy. It's an earlier change than hemorrhages and MAs, etc. And that got me looking and thinking of other studies. I challenge you to go onto the web tonight and just Google enlargement of the foveal vascular zone in OCT angiography, and I came up with 4 or 5 studies in just a matter of 3 minutes. And you're going to see more and more on the enlargement of that F.A.A.O in these patients' early detection. The other thing is qualitative and quantitative data, capillary dropout, non-perfusion, losing some of those capillaries. We can't see the capillaries in the macula. We can't see the capillaries in the fovea. They're too fine to see. We can image them with fluorescein. The downsides are the injection and other downsides, as we've talked about, and be able to image that in a matter of seconds and be able to see ischemia, non-perfusion, capillary dropout is certainly key. And then looking at IRMA or early neo, shunt vessels, collateral vessels versus neo of the disc, isolating what area of the retina is that in. Is it on the surface? Is it in the vitreous just a little bit? And neo, therefore, to be able to image those is certainly going to be a game changer as well. So I'm going to go back one slide. What are the advantages? Early detection. Early detection, F.A.Z enlargement, capillary dropout, vessel density, very key. Less invasive, quick acquisition time. Again, I did a bunch of scans today with OCT angiography, and you can get the scans usually in less than 5 seconds, if not 2 or 3 seconds, with a very cooperative patient, which is very, very nice. It looks at multiple layers of the retina. A fluorescein angiogram, you're seeing the very superficial retina. A fluorescein can actually detect more MAs than an OCTA. We'll talk about one of the disadvantages of OCTAs. It may not pick up as many MAs as a fluorescein. That's been proven in the literature, and there's reasons why, which we'll discuss. But it can't image multiple different retinal layers as you go deeper and deeper and deeper, because you're just looking at the picture of the fundus during that fluorescein. OCTA can look at multiple different layers. What's going on in the superficial retina? What's going on in the deep capillary plexus? What's going on in the outer retina? You can do that with OCT angiography. So we talked about that. It localizes the MAs to their exact retinal depth. And again, it's not dependent on contrast. So it can image without leakage, without pooling, which is very, very nice. So we talked about this already. Again, the macular ischemia enlargement, the foveolae vascular zone, capillary dropout. Once again, I'll have you take a look at this. A very, very normal scan. This is from our normal patient from earlier versus watch as we transition to the next slide. That's the deep capillary plexus. And there is the superficial capillary plexus, a normal versus the deep. And you'll take a look at this patient with an early diabetic, the remodeling of the foveolae vascular zone. If you look at the overall area, in the diabetic on the right, the area of the F.A.Z is bigger. The perimeter of the F.A.Z is bigger as well, and you would be able to see capillary dropout in this macular area in this patient at the level of the superficial plexus. A little bit deeper, here's the deep capillary plexus. And once again, there it is. And you can see the remodeling, the capillary dropout, the F.A.Z area enlargement, the perimeter enlargement as well, which we'll get into a little bit more in just a second. So remember those indications. A quick case. I want to thank my good friend and colleague, Julie, for providing this. And this is a diabetic patient, 45-year-old female, A1C 7.0. And you take a look at the fundus, kind of a 30,000-foot view. Overall, doesn't look bad. On-FOS OCT looks pretty good, correct? And then you image the OCTA. Whereas this patient you may have followed in 6 to 12 months, maybe 12 months, now you're seeing changes where the F.A.Z looks enlarged. Capillary dropout. You're seeing the MAs here as well. This patient has some degree of ischemia going on, and this needs to be looked at, needs to be evaluated carefully, education, and follow closely on both of those. Another case, diabetic patient, again, blood sugar never been overly high. The B scans look good. There's some exudates, no edema. And again, you take a look, and we've got some microaneurysms identified. We've got some capillary dropout identified. And remember, we're looking at the 2 scans on the left. 2 scans on the left are the key. The 2 on the right are more of our outer retinal pathology, macular degeneration, central serous, histoplasmosis, pathological myopia, etc. Those 2 on the right. The 2 on the left are the ones that are going to show the changes, and they do here in this case of diabetic retinopathy. So remember the indications as we've seen right there. Another on-FOS, more severe now. Those last ones were on the relative mild to moderate stage. You take a look at these 2 on the left, and we've got severe capillary dropout, drastic enlargement of the foveolae vascular zone. There's a tremendous amount of ischemia going on. This patient's rate of likely progression is high and quick in this patient based on the capillary dropout and the ischemia that you're seeing. We know the angiogenic factors are likely going nutso right here, going pretty crazy with the amount of ischemia going on in the superficial and deep capillary plexus. More changes, non-proliferative diabetic retinopathy. You take a look, and especially in that case 1 on the left side, look at the bottom right, the capillary dropout there. And the F.A.Z is being remodeled as well in that one. So those are certainly some of the advantages. What are the disadvantages? Disadvantage when you take a look at this, it requires a longer fixation. Fluorescein angiogram can take a picture in a snap second. You just snap the photo, and that one photo is done, versus it's going to require 2, 3, 4 seconds of fixation, depending on the patient, good fixation to get that get that OCTA scan. Again, it's motion contrast. So you need good fixation for a couple of seconds, but we all know the entire procedure or the entire scan is much less than a fluorescein angiogram. It does not, smaller field of view. OCT angiogram, again, we've utilized this up to 8 millimeters. You can montage it up to 12 millimeters, and technology is looking better and better to getting even beyond that. But fluorescein really can go from very peripheral retina to very peripheral retina. And so you can't get out quite as far, harder to view the image peripherally, but, that's one of the downsides. The number of identified MAs was less than studies with the fluorescein, as I talked about earlier. This was a study looking at the number of MAs identified in a fluorescein angiogram on the left versus in an OCT angiogram on the right. And you will notice that it's not as many MAs in the OCTA images on the right. However, remember that it can image at different layers in the retina versus just that one layer with a fluorescein angiogram. What's the reason for this? It's because you can have some MAs are very low flow MAs. And if they're very low flow over the course of a 2, 3, 4 second image, nothing's going to move, or very little will move. And if no blood moves, if no erythrocytes or red blood cells move, the OCT angiogram is not going to image it. So if you have a very low flow microaneurysm where there's minimal blood moving, it's going to have a difficulty detecting that MA. All right, long-standing 30-year-old diabetic case. The purpose of OCT angiography is to detect it before this. This is obviously showing this patient had moderate to severe NPDR, and you take a look at the capillary dropout. Again, the 2 scans on the left, and that dense plushness or lushness of those capillaries. There's the superficial capillary plexus. There's the deep capillary plexus. And both of them, there really almost is no capillaries left at this point. A tremendous amount of ischemia, non-perfusion, capillary dropout, enlargement of the F.A.A.O in this patient. RPE level looks pretty good. Choriocapillaris looks pretty good as well. Again, we didn't have an issue with that in this case. Overall, again, long-standing diabetic. The point is to detect and use OCTA way before this to maybe help more patients not get to this level in this case of a long-standing diabetic. How about a vein occlusion? This was a patient that had reduced vision in the right eye and had that 1 or 2 lines reduced vision in the left eye. Now, he had a vein occlusion in the right eye, so we knew why the vision was down. You look at that OCT B scan on the left side on this right eye, and you can clearly see that there's PIL disruption, outer retinal atrophy. We know why this patient has lost vision in the right eye. But the left eye was down a line or 2. Again, that 20/25 minus 20/30 plus diabetic. There is no edema in the left eye, but you take a look at this left eye. Again, this is the non-vein occlusion eye, and once again, those 2 scans on the left don't look very good. Capillary dropout, areas of non-perfusion. This was before we had analytics, but if we were measuring the vessel density, and these 2 on the left, which we'll go through in just a second, those numbers would be very, very poor, very, very low in this case. How about the right eye? This is the vein occlusion eye. And what's cool is you take a look at this image on the left side. Where was the vein occlusion? Was it superior or was it inferior? And the answer was obviously it was inferior. You can see all of the capillary dropout. Now, the capillaries aren't great on the superior half, but they're even worse on the inferior half because he had an inferior vein occlusion in this right eye right here. There's the deep capillary plexus, as you can see as well. RPE level looked fine. And the choriocapillaris look fine as well. Again, we wouldn't expect any major changes in diabetes or retinal vascular disease. So, again, we went through normal. One more time, look at this. Here's the normal. And watch this. In an early diabetic, one of the most profound F.A.A.O enlargements that I have seen. Again, there's the early diabetic, and that F.A.A.O area is much bigger here compared to, there was the normal. One more time. And there was the early diabetic. And you can see some MAs on this scan. You can see the F.A.A.O perimeters getting bigger, the areas getting bigger, and you can certainly see some capillary dropout in that area as well. So this is something that really we've started scanning almost all of our diabetics. When we have a diabetic come in to get an OCT angiogram to see what does that capillary network look like in these patients. So we've went through all of the advantages already. This leads us right into analytics. The vessel density maps. It's great to look at this picture. And I'm sure you all appreciate looking at a picture like this. It's phenomenal technology. And it's even better when you can get analytics or numbers to help quantify what exactly am I seeing exactly how much capillary dropout or vessel density loss am I seeing as well. And in this patient, you can clearly see, or different patients of normal, mild, moderate, severe, and proliferative diabetic retinopathy, as they're going across the different stages, the vessel density is decreasing. That vessel density is going down, and that brings in Angio Analytics. And this is, again, the numbers behind the imaging of the blood flow. Give us some numbers. We all like numbers in our regular OCT. When managing glaucoma, looking at that retinal nerve fiber layer, looking at the individual quadrants, the sector analysis, ganglion cell analysis, we all look at those numbers, and we want numbers in OCT angiography as well, and that's the Angio Analytics. It will look at flow, abnormal flow, developing blood vessels that shouldn't be there. The biggest indication here in flow area measurements is in choroidal neovascular membranes. Again, that's a topic for a different webinar, but this is, again, more so the outer retina, looking at blood vessels that shouldn't be there. How about areas of non-flow? As capillaries are dropping out, they're no longer providing flow or blood flow, and therefore that's an area of non-flow. And if that's getting bigger, if we can measure that via vessel density maps, that's going to have a tremendous indication in diabetic retinopathy and vein and artery occlusions, retinal vascular disease. Again, this is what we're now doing with our analytics. Here's what I wanted to spend a minute or two on, the F.A.A.O measurements. Again, I've got 4 different studies that I just looked up real quickly showing how prevalent and important this is in early diabetic retinopathy before you can see changes on the retina. What do we look at? Remember, this is available in your 3mm and 6mm scans. Usually I'm doing 6mm scans. Highly repeatable. There's 3 measurements that I look at. Again, you can clearly see that the F.A.A.O is enlarged, remodeled, the perimeter is a little jagged here and getting bigger. But you want to look at these 3 numbers right across here. Okay, at the top, F.A.A.O, perimeter, and the foveal density of capillaries, the vessel density within the 300 microns of the F.A.A.O. Those 3 numbers are now provided to us so we can look at these patients and over time measure how are those doing over time. Hopefully they stay stable, but if you're seeing a deterioration, we need to recommit to managing blood pressure, blood sugar, maybe a diabetic supplement, follow that patient more closely. Maybe you consider other testing as well, which we'll talk about in just a little bit. So look at those 3 numbers, and I'll show you how to get there in just a second. Vessel density maps. Again, looking at the superficial capillary plexus and the deep capillary plexus. With our talk today, we're focusing on diabetic retinopathy. This top image is your nice 6mm scan, and you'll notice it's broken down into 9 little sectors. And each one, it now gives you a reading of what's the vessel density in that quadrant. And again, now you have numbers to compare over time, saying, how is it doing overall? How is it doing in the superior half? How is it doing in the inferior half? How is it doing in each of the 9 little squares as well? So you can now follow this patient over time with numbers. That's your vessel density maps, once again, to go along with your F.A.A.O measurements right there. Clinical applications, again, early vascular changes in these diabetics. As we've talked about, again, you take a look at this and you can see the diabetic, or this fundus photo with minimal changes in the back of the eye, and yet compared to a normal OCT angiogram, notice on the right the nice capillary network there. You can get that nice network versus the F.A.A.O is bigger, the perimeter of the F.A.A.O is bigger, and your vessel density, you're seeing those blue spots, those vessels dropping out, capillary non-perfusion right there, early changes in diabetics. We've talked about the F.A.A.O already. What's the normal area? Again, in my experience, I've imaged a lot of normals. I've imaged a lot of diabetics. This is a nice representation on the right. What do you expect the F.A.A.O area to be? In my experience, it's between 0.1 and 0.2 millimeters squared. 0.1 to 0.2, maybe in the low 0.2s, but 0.1 to 0.2 millimeters squared. And you can see in this normal eye of 0.172, perfectly normal. And in your diabetics, we've got a significantly bigger one here, 0.443, that early F.A.A.O change in this diabetic. Other things that you can look at, obviously wellness scans. You can pair with this and use the OCT to reveal small vessel loss. And how does this change things? How will management change? Well, I would like to think that if I was told I had an abnormality on an angiogram on my heart, that the doctor might consider further testing. The doctor might consider starting me on some medications, diet and exercise, maybe a supplement. But again, further testing and more close follow-up, I think, is going to be key. And the same thing is here. You look at that diabetic and you're not seeing any changes in the retina, but yet you're seeing what's an abnormally enlarged F.A.Z, or maybe you're seeing reduced vessel density. Maybe you consider a visual field. Maybe you're following the patient more closely, additional visits. Maybe you consider an ERG. We do a lot of electrophysiology. I do a lot of ERGs in our diabetic patients. So looking at this and really embracing the medical model, diagnosing diabetic retinopathy sooner. I do believe that the earlier somebody is diagnosed correctly, that the better, and the earlier they're managed appropriately, the likely the better long-term outcome. I always tell the story. I was born and raised in North Dakota, and I have an extensive family history of multiple sclerosis. I have 7 family members on my mom's side that have MS, and my aunt was diagnosed about 15 years ago, and she was diagnosed relatively early in the course of her disease, and her neurologist told her, "You're going to do better, we think, because we caught this earlier, we think." And I believe the same holds true with diabetic retinopathy. Earlier proper diagnosis and appropriate management, following closely, leads to potentially better long-term outcomes as well. So again, here's another F.A.Z enlargement, and watching this over time. Mild NPDR, moderate NPDR, severe, notice the numbers. There's a trend as the ischemia gets worse, the size of the F.A.Z gets bigger and bigger. Remember, normals, 0.1 to 0.2. That's typically more, I see most normals right in the 0.1 to 0.2. I've seen a few diabetics that were very, very well controlled. They're very mild diabetics, not retinopathy, but very well controlled diabetics. Haven't had it that long. I had one today where I had an F.A.Z area of 0.15, right in the middle of the normal range, but he was a diabetic, well controlled, really just controlled it with diet. And so he's got a better prognosis because of that F.A.Z being very, very normal. I'm feeling better about the development of his diabetic retinopathy, maybe slim, or may progress much more slowly. Here's the vessel density. Again, this is the other thing to look at. F.A.Z was one of them right here, and the vessel densities, as you can see clearly over time. This is a qualitative image with some numbers on top, is decreasing as well, and you can follow this over time. We've talked about the F.A.Z following this over time as well. Trend analysis is key. We all do this in our glaucoma patients. I would encourage you to do this in your diabetic patients as well, as you're looking at the F.A.Z vessel density as well. This is certainly involved in glaucoma. Again, my talk isn't on glaucoma tonight. Somebody else is going to talk on glaucoma, and they're going to do a fabulous job. But you can clearly see the loss of that retinal nerve fiber layer and a loss of that vessel density, that capillary network around the nerve in this glaucoma patient. So the last 2 slides that I really want to finish with in terms of interpretation, and these are both on the disc, but I want you to imagine as if they were on the retina as well. This is now with analytics. And when you take a look at this, again, this is right over the disc. This is an OCT angiogram of the optic disc, and you can take a look. We've got a nice image here. We've got the OCT angiogram on the left with the B-scan below, and the on-FOS image on the right with the B-scan below. And notice on the right side here, you've now got a table, and it's showing you the vessel density in all of these different areas over the whole image, in this case inside the disc, parapapillary, etc. If this was a retina scan, it would give you the whole macula. Again, it would divide the macula into these 9 quadrants in the bottom. Look at the bottom right section down here, and you'll notice just above that a grid-based vessel density. And you can see there's 9 grids, and you can see those 9 different readings. Here's the vessel density in the top left versus the upper middle versus the top right. And you can, over time, you can see how are these vessel densities doing. Again, this is of the nerve. This would be a picture of the macula if this was an OCT angiogram of the retina. How do you get here? This is what I wanted to mention from earlier. Notice at the top of this scan, we've got scan quality, top central, scan quality. And there's our 5 or 6 different tabs. You want to hit the on-FOS tab. And when you hit the on-FOS tab, again, there's other things you can look at, thickness, color overlay, etc. But when you hit on-FOS, it's going to bring up this screen. And then very importantly, you want to go over to the left. Top left side, under HD Angio Disc, you'll see there's a measure box. Click the down arrow, and you will see F.A.Z. You will see density. That's what we're looking at here. You will see flow. You will see non-flow. In your diabetics, I mostly look at F.A.Z and density, okay? And that's what that will look like. And we've seen how all those images look, but that's how I get to what the images and the numbers that I want to look at in my diabetics as I'm interpreting this. Again, go back to ONFOS, that tab, and then over to the left and look at F.A.Z. And when you hit F.A.Z, it's going to look like, let me go back here a couple slides. It's going to look like, hold on, I'll get there, just like this. And you're going to see at the top of your image, there's your numbers, the F.A.Z area, the F.A.Z perimeter, and the foveal, the vessel density in the center part. Within basically that circle, within that circle that you're seeing right there, that's the last number. So those are your three numbers that you are going to get when you look at that drop-down area. Let me get back to this here. That's the three numbers that you're going to get when you hit F.A.Z in the top left. Density, you're going to get this printout right here. And again, this is of the nerve, but it would look like that for the retina if this is an OCT angiogram of the retina or the macula. And then you take a look at this, and again, this is for glaucoma, the interpretation reports, where you can have on the left all of the retinal nerve fiber layer, the normal numbers that we're expecting. We've all seen these before in our regular OCT printouts, and you've got the angio on the right with the vessel densities around the disc, peripapillary, etc. Again, this is very, very exciting in terms of glaucoma, and stay tuned for another webinar coming up very soon on OCTA in glaucoma as well. Again, stay tuned for in abnormal flow in the outer retina, AMD, central serous, etc. Right there. But again, our topic today was in diabetes and going through what do we look at in diabetes and diabetic retinopathy, how to interpret OCT angiography. With that, those are our indications. This is our final slide, and I am going to go to a question and answer. Okay, and I'm pulling up the question and answer here. Let me make this bigger here. The question is, how do I acquire an ONFOS scan to check for angiography? When you've got OCT angiography on your system, in terms of acquiring the scan, you just click on the protocol that says OCT angiogram for the retina, 3 millimeter, 6 millimeter, 8 millimeter. It automatically knows that it's scanning in that way when you're doing an angiogram. So you don't have to click an ONFOS button to do that. It will automatically acquire that OCT angiogram when you click on the scan, when you click on the way to acquire that. Is there a normative value for the diameter of the foveal avascular zone for a healthy individual versus one for a diabetic? And that's a great question. That is being developed right now. We've had OCT angiogram for almost 3 years, and it gave us great qualitative images. You know, as we looked at earlier, and I know you guys can't see the question and answer, but this is a great, I'm going to push that to the audience here. You can see that's a great qualitative image, meaning you can look at that and see the capillaries and see the F.A.Z, and that's all we had for a couple of years. And then the next advancement, the next level was the analytics, which gave you the numbers. Basically, give me a vessel density number in each quadrant, in each sector. Give me the size of the F.A.Z, and that's what we have. And the next step after that is going to be, let's compare that number to a reference database, compared to age-matched norms or an age-matched reference database. So that's going to be the next step. So is there a normative value for the diameter of the F.A.Z? For the area of the F.A.Z, again, a healthy individual, my clinical experience is between 0.1 and 0.2. As you go to about 0.25 to 0.3, to me, I've seen that a lot in diabetics without retinopathy. And the more advanced the retinopathy is, it gets from a 0.3, 0.4, 0.5, and beyond. Hopefully we have a lot of questions coming in here. Let me take a look. I see a couple on billing. How do you bill OCTA? At this point in time, OCTA, there is no separate code for OCT angiography. It is the same as a regular OCT billing. So there is no additional code for OCT angiography. If our patient has no retinopathy, how do you bill for it? Well, can you bill an OCT in a diabetic without retinopathy? I've heard different answers on that. I would lean towards potentially no. If you don't have any, if your diabetic is, the macula looks good and they're 2015 and there's no diabetic retinopathy and the sugar is well controlled, typically we're not billing an OCT. We may do it for purposes of just doing the OCT and getting the data. OCT angiogram, same thing. We don't typically bill it if they have no retinopathy, but you could. Again, I've heard it both ways. But if they have an abnormal OCT angiogram, the literature is supporting now that that is a subclinical diabetic retinopathy, and you need to consider, will you now code them mild diabetic retinopathy? What do you consider to be an acceptable scan quality? Acceptable scan quality to me is a 6 and above. If I can get a 6 and above, that's good. I'd prefer an 8 and above. So if I can get an 8 and above, great. But if you can get a 6 and above, that is acceptable. If I've got a 5 or below, we tend to repeat that scan for a 5 and below. For a 6 and above, acceptable. Again, I really try to get a 7, 8, 9. Those are the most common. It's unusual that we get 10s unless they're in a very normal, young, healthy patient. But 7s, 8s, and 9s are really where we like to get that. So that's what we consider acceptable scan quality. Any tips on getting quality scans? Good fixation is key. Again, they do require good fixation. Remember, motion contrast. So if the patient is moving, that is motion. The patient's eyes are moving, that is motion. So if they're moving their eyes, it's going to throw the scan off. They need good fixation for 2, 3, 4 seconds. And then remember that ocular surface. Again, if we're having any issues, put a drop of artificial tears in to refresh that surface, and that will help with some scan acquisition along with fixation. Give the patient breaks if they need to, but most often they don't. And just remember that surface and that media when acquiring those images. Let me see here. What do you look for? I've had multiple questions on how do you differentiate IRMA versus neovascularization, or how do you look for IRMA versus neovascularization? What do you look for to confirm proliferative diabetic retinopathy? So remember the different retinal layers, and this is the beauty with OCT angiogram, is you've got different retinal layers, and you can detect an anomalous vessel in the superficial capillary plexus versus the deep versus the outer retina. If you are seeing an anomalous vessel in the retina, meaning in the deep capillary plexus, maybe the superficial, but more likely the deep capillary plexus, and you're seeing, boy, that vessel looks weird. That shouldn't be there. That looks abnormal. That could be IRMA. IRMA is an intraretinal, meaning it's within the retina, versus neo. Neo has to have a framework to grow. It's going to grow in the vitreous. It's going to grow on the surface of the retina and into the aspects of the vitreous. So you're going to be able to image that above the level of those capillary plexi. So that's how you're going to differentiate that, looking at your different scans. If the vessel is showing it being anomalous in the superficial or deep plexus, IRMA. If you're imaging it, it's just above the superficial capillary plexus on the surface of the retina, that's much more likely neo. Do we refer for enlargement of the foveolae vascular zone? I would say no on that. If I see an enlargement of the F.A.A.O, am I referring that patient out to retina? No, not at that point. I would recommend that we follow that patient more closely. Maybe instead of, again, how often do you guys see that patient with no retinopathy? Let's say their vision's relatively good, 20/20, 20/25, their vision's, again, good. They have no diabetic retinopathy. I'm guessing you're seeing that patient in a year. I would probably examine that patient in 6 months. I'd follow that patient more closely, maybe even 4 months, depending on the enlargement of the F.A.A.O, how much capillary dropout it is. I would consider maybe a supplement in that patient. I would consider maybe you consider an ERG at that point. We do a lot of ERGs already because this pairs to me very well with structure function, OCTA, ERG. So those are things that I would consider in terms of doing that. So would I refer out? No, I would follow that patient more closely, potentially further testing, potentially a supplement, more stringent education that you are at risk because of the early signs we are seeing on progressing through that diabetic retinopathy. Do you scan all diabetics at every visit? We don't scan all diabetics. If they have any degree of vision loss, if they are uncontrolled, If we see any diabetic retinopathy, we will do that. But I am leaning more and more. I've changed my protocol over the course of the last year or so on, boy, even a baseline scan. Maybe you don't do it every year, but you're diabetic to do a baseline scan. I understand you may not be able to bill for that, and we've talked about the billing, but to be able to get a baseline OCT angiogram, and maybe you don't do it next year or the year after, maybe you do, but maybe you don't do it because you got your baseline, vision's good, back of the eye looks good, their A1C's 5.8. Maybe you don't do it for year 2, 3, 4, but you got it for the baseline. So I'm especially recommending a baseline, and I'm even starting to consider going, if you're doing an OCT, do an OCT angiography, and I might even be leaning for an OCT angiography even before that as well. Do you dilate for all angio scans? In my experience, that's going to depend on their age. It's going to depend on the instrument that you're utilizing. We have the OptiView Avante OCT angiography, and to me, that does a really good job on undilated pupils. Getting scans without dilating the pupils, it's done very, very good. If patients are under the ages of 60, we tend to get a lot of good scans without dilation. Not all of them, but a lot of good scans without dilation. If they're over the age of 60, typically it's looking at looking at a dilation at that point in time. So that's how we typically do that. With that, I'm looking for any last. What diabetic supplements? There's a number of supplements out there. Again, I would just look at next exhibit hall or next conference that you look at to diabetic supplements. We've used different ones. I do like the Zia Vision Diabetic Vision Supplement, so I think that's a nice one. But we've used there's a lot of good diabetic supplements out there. Last questions here. Is there a link? Is there a link with following the F.A.A.O and Alzheimer's and dementia? That's a good question. I'm not aware of that. I may not have stumbled across that study at this point, but I'm not aware. I'm sure we've all been told that there's a link between OCT findings and Alzheimer's dementia for a regular OCT, a nerve fiber layer, ganglion cells. Is there a link between the F.A.A.O and Alzheimer's dementia? I don't know at this point. I haven't stumbled across it. That's not to say that it's not out there at this point in time. So with that, again, we couldn't get all of the questions answered. We got a good chunk of them. If you have any further questions, certainly contact your local OptiView rep, and they would be happy to help you. One of the questions is, how do I know if my OCT has OCT angiography function? I think that's a great question for your local OptiView rep to ask them if they've got OCTA function, and I'm sure if it doesn't, they'll help you out. And if it does, they'll help you to understand and recognize how to get to the OCT angiography scans. I think we've got all of the questions. With that, I want to thank everybody for attending this webinar on OCT angiography in your diabetics, how to look at normal, how to evaluate in your diabetics. I want to thank you for your time, and I hope you have a great evening. Good night, everybody.